parents have to realize, like, if you've been mouth breathing your whole life and you're 7 or 8, your maxilla is too far back. You are probably narrow. And unless you have really good genes and you can somehow avoid that, it's going to happen. But what we're seeing, and from my perspective and in any like airway dentistry perspectives, is that these kids, you can tell they've got issues. Their baby teeth are crowded, they're narrow when they're 3 or 4. So now we're saying, oh, we see the problems today. We're just going to wait 3 years to correct that. That's crazy, right? The times are changing, and dentists are they're eager for information about this stuff. So I think the implementation is where we're getting stuck a bit, because it's great to have all the knowledge, but like, how do you change the way an entire office operates, and how do you be profitable? And so that's really, I think, the biggest question right now.
Get ready for your unofficial dental hygiene podcast. These are the tales of two hygienists, one East Coast RDH and one West Coast hygienist. Listen as they tackle the profession of dental hygiene with humor and enthusiasm. Now, please join Michelle Strange and Andrew Johnston as they tell you a tale of two hygienists.
Welcome back, everyone, to another episode of A Tale of Two Hygienists. This is episode number 211. My name is Andrew.
What? My name is Michelle.
Oh, are we doing that now? Just like one-upsmanship there. Okay. No, I like it. Well, happy middle of January to you, ma'am. End of January.
Thank you. I just got a funny meme from my BFF KP, and it said,
Wait. Isn't KP the one that got you sick? I thought we were hating her right now.
I've recovered since. Yeah, but she was
KP.
The carrier. Patient zero carrier.
Okay.
From when I lost my voice.
I'll get over that.
She's going back to Liberia. She's going back to Southern Sudan to do a mission trip there with Doctors Without Borders.
Wow.
Love her. So she sends me these hilarious things. And it says, they say 40 is the new 30 and 50 is the new 40. But all I know is the older I get, more 9 p.m. is the new midnight. And that has never been truer. Words spoken for me. Because we didn't talk about our New Year's or anything, but I did go to like a little house gathering with my friend Lindsay. We got there at we had dinner at her house and like hung out and had some pre-drinks and Ubered over. And we got there at like 9 o'clock. And I was like, so we're staying until midnight? Like that's the thing that we're doing? Like, and she's like, shut up. It's one time. It's just so late.
So you ended up staying up till midnight then?
I'm not joking. Like if you went and looked at my Uber history, I think at 12:01 and 15 seconds, I hit the Uber.
That doesn't
come back and get me.
Oh my gosh, that doesn't surprise me at all. Good for you.
It's like, yay, Happy New Year. They'll be here in 3 minutes. Say your goodbye.
It was the same thing with the kids. Which is weird because I told all my patients leading up to, I'm like, hey, what are you guys doing? They're like, oh, we're going to do this. I'm like, 9:30, I'll be in bed. And then I ended up staying up, which was stupid.
Yeah, you text me.
Yeah, didn't get a text back, but whatever. Just because it was 3:30 in the morning, whatever. But anyways, so it was like 12:02. I'm like, the kids look at me and they're like, okay, well, now what? I'm like, now you go to bed. So good night. And I made them go to bed.
That's all it is, guys. Just watch those.
So terrible.
That ball drop, and it's such amateur night. I can't even stand to go out. But anywho, we're weeks past it. I don't know why we didn't talk about that originally in our first.
Well, it's because we had the student
episode of the
student year. Focus was the first one.
Yeah, we had the student focus. But anywho, this is a hygiene podcast, guys.
Yes,
we're not talking about hygiene right now, but this is if this is the first time, if you're tuning in for this Myofunctional series, we're glad you're here. Hit subscribe. We would love you to do that, and also leave us a review. We want to get to as many reviews as possible. And I'm going to be real frank with everybody. Dentists, they're crushing us in the podcast listening world.
They really are. I mean, look,
I'm not okay with
we're doing pretty good. You guys have been very supportive. So I don't want to throw you guys under the bus, but they do a much better job of engaging, I think, with their friends that are also dentists and then sharing that particular part out. So if you are a student listening to this, share it with your class, share it with your office. If you're in practice, just share it with everybody. Everyone can get better.
Exactly. And because they're learning at rapid speeds, listening to these podcasts. And that was what our goal was for our hygiene community. It was just to make you guys have the most current, up-to-date, evidence-based content to make you better clinicians that are less frustrated. I think that was kind of our original goal, because we know that, information can really change your perspective.
Yep. All right. So I have a question for you. So this is actually kind of playing on the theme of New Year's resolutions, which we never talked about, but there have been many of our friends or whatever who have thought like, okay, look, 2020, I'm going to be finding myself a new job. Not that my job is bad now, but like I could level up, so to speak. So my question for you is this: if you were looking for a new job, maybe like a 30-hour a week, something that's mostly full-time, and it doesn't matter if it's like a traditional, like a restorative office or perio office or whatever, what are you, Michelle Strange, looking for? Follow-up question is, what are you looking for the average hygienist that's been doing traditional their whole life?
I think first and foremost would be an office that embraced change and progression and technology. My first thing was like, I want airflow. I want a PA's on. Like, I want intraoral scanning. I want bacteria testing. I want to make sure I have oral ID for oral. Like, that was my initial, like, these are the things that I'd want. But I think the culture of the office that I would like to be in is one where we are really working on our growth of the practice, our growth in patient care, our communication skills. I mean, what I learned with Corey and Custom Dental Solutions 2 months ago was the most enlightening thing I think I've ever learned as a clinician. It really kind of defined why I like to do the things that I like to do in a particular office. And of course, it wasn't production based. It was, how can I get a patient healthier and do right by them? I think it would be more about the culture of the practice. Are we going to courses together? Are we training together? Are we having huddles together? Are we doing monthly meetings together? Can we have good, lively debates about research and technology and techniques without the animosity and the contention that comes along with it a lot of times? Do we support each other? And am I valued for what I'm bringing and my willingness to grow? I think that would be the office that I would want. And I would hope that for I say quote unquote average. I don't think any of us are really average, but like the everyday in the trenches, 30 to 40 hours a week in some cases, I would want that for them too.
It's interesting. And I didn't hear how much you get paid, benefits, anything about that. None of that really hit on your hierarchy, which I think is interesting, because
honestly, I didn't even think about it.
What is one of the number one questions of, hey, in Pennsylvania, what's the average pay rate? Like, that question happens all the time on social media.
You're so right. Yeah, it did not even dawn on me, because I've made decent money and I've made very basic out of hygiene school. I thought I was asking for a lot and it was like pennies. So I've been on both ends of it. And as much as I am okay with getting paid pretty well, I don't want to make $50 and $60 an hour and hate my life the 8 hours that I am in there. Like, that sounds horrible. I've been in, weird. This marks 20 years that I've been in dentistry this year.
Yay, congratulations.
May will be 20 years since I started in dentistry as a dental assistant. And I, at this point, put more value on being valued and also taken care of. Like, does my office leader, doctor, business owner, whoever it is at where we are, because that looks so different now in a lot of different offices.
Right.
Are they sending us to CE? Are they, bringing in lunch occasionally? Are they making sure if I'm like, hey, I really need a saddle stool, my back is killing me? Like, we talk about that. Like, they're not, I know they're not like just tossing money at me left and right, because I'm also in public health. So now I'm really understanding a budget these days. Are you willing to help me help myself, take care of myself so I can practice longer and keep doing better for the patients that we're all seeing together? But yeah, I don't care if that's at $25 or I need to make money. I need to pay my bills. Like, that's I mean, that's a different conversation, but
yeah.
Never thought about it.
For the listeners that are just kind of coming in that are newer to the podcast, we have a bunch of back episodes on kind of like job search and things like that, like some questions to ask the dentist, which I think is also another important thing. Is you talked about the collaborative culture. Part of like when you're looking for a new job, I think you should be able to sit down and talk to the dentist if that's your partner that you're gonna be working with all the time. You guys kind of need to have, similar philosophies and do they have a perio protocol? A lot of them don't, surprisingly.
And if they don't, are they willing?
Right.
If I can bring you the science, if I can do the legwork, are you willing to implement this into a practice? Is the office as a whole open to that? Again, I keep going back to Corey's assessment. Like it talks about like, who are the people in your office? Are they a little slower to change? I need to know that. So I'm just not like a bulldozer coming in here, like infection control changes and Cavitron changes. We're going to use a piezo now. Like, and everybody just has anxiety. And now I'm a hated human in there. I think that culture, you really do need to know what you're stepping into as well. What about you?
Oh, buddy. I'm
curious why, what struck you and what made you think or to ask that?
Oh, just social media.
Because you were seeing some things?
Yeah. Social media always talks about like, hey, this is what we're going to do for 2020. This is my New Year's resolution. Oh, I'm looking for a new job. I want to upgrade. I want to do this. I want to do that. So I'm like, oh, okay. That's something we haven't talked about in a little bit. I think the things that are important for me are just, I like the collaborative culture. Like so my doctor and I need to be on the same page. And even if we're not on the same page, they just need to be open to me. So it's always been a hard thing kind of throughout my career of when I work in a place where the doctor is also an employee, like I'm an employee and not necessarily my boss. To me, that gives me a little bit more leeway to have that kind of like, hey, colleague, let's talk about these things together. Let's get on the same page. Teach me what you know. Let me teach you what I know. This is what I just heard at all the we go to so many courses. Here's a course that I heard, or this is the thing that I heard at a course. And like, are you open to me doing this and that? So at first, there's a lot of resistance with a lot of these doctors, but then like they seem to get like my ulterior motive is not to like put them in a place where they don't understand things. It's to make them better, to make me better, to make the patient better, to make the practice better. And so I think collaborative like culture is like number one for me. But also I need to be able to have the tools that I need to do the job the way I like to do them. I don't want to go into a place where I've said this before. I don't like sharpening instruments. I don't want to have to sharpen my instruments. So I would like a budget to get sharpen free instruments so I don't have to do it. I will gladly pay for them out of my own pocket, but I would prefer not to. I also would like to have the time off, to do the CE that I want to do the traveling that you and I get to do. So that is a thing. And then, enough money to be able to, pay the bills.
You said, they're saying like 2020, I want to level up. I want to go to a new practice. I want to do these things. And I'm questioning, which is not something I would have ever, I've been like, yeah, you go get yourself another office. Like they're not fitting well with you anymore. It's time to move on. Mm-hmm. But now I'm like, what is it? Like, because grass isn't always greener. If you already have these established patients that you love, maybe if it's just a toxic office, you need to keep on keeping on, sure. get on out, sure. Right? But if it's not a toxic office and you feel like they're not leveling up and you want to level up, like, could you be the leader of that initiative in this practice? Why do you have to leave in a way?
Well, I think that's a great point. I think that we've had several of our listeners reach out to us and let us know that they've become the leaders in their offices. And I think in some offices that really works, especially private practices. But when ends up being corporate models, which a lot of offices are corporate models now, either there's not a space for you or management above you doesn't have the same philosophies as you do, or necessarily care about you as the individual the same way as they care about the whole office as a whole. And so maybe they're a little short-sighted on some of those things. And so I think there's lots of opportunity for people to want to level up, and they realize that they can't do it in their current situation. It doesn't necessarily mean that all offices are toxic and that's why they left them. But sometimes, you've maxed out.
Yeah, it's true. Yeah, maybe you've outgrown them and they're just not willing to grow with you. Then it's time to move on. And you know what? After this series that we're doing, this myofunctional, because we're in part 3 of this 4-part series, you're going to be like, that's where I want to go. Mm-hmm. Like, I need to do something like this. So maybe it's a very outside of the box of the traditional dental hygiene role or what that model looks like, which I am so ready to move past. I know, God, I wish our school would change. Biofilm, guys, not calculus. But anywho, I'll save that soapbox for another day because I want to get into this part 3 of this series. I hope you guys are enjoying it. Again, if you are just tuning in because you're like, myofunctional, that's so cool, I want to learn about that, please hit subscribe. We would love that. Send us your feedback or leave us a review. You can always email us. You can email me, Michelle, at taleoftwohygienist.com, or just head over to our website, taleoftwohygienist.com. Sarah gives all of her contact information at the end of each episode. So if you want to contact her, stick around and get that. It's also going to be in our show notes. And I hope you guys really are enjoying it because it was fascinating for me to learn from her. She is a wealth of knowledge and really a change maker in our industry. So continue to enjoy this part 3 of 4 Myofunctional series with Sarah Hornsby.
Hey, Michelle.
Yeah.
It's time for the interview.
Oh, but I had something else to say.
We need to let the experts talk now.
Fine.
Listeners, I'm sure you are almost like, give me the next week. Like you can't wait. One of these episodes ends, you're like, God, I got to wait a week. And if you're lucky enough to knock all these out back to back, I'm sure your mind is just like, wheels are turning. So I want to thank you again, Sarah Hornsby, for coming back on the podcast. This will be our episode 3 in this myofunctional therapy series that we're doing. And Sarah, you've already just taught me so much.
Good.
So thank you so much for taking the time and coming back on.
Yeah, I'm happy to be here. And I know we talked about a lot of overview stuff and babies, and now we're focusing on the kids and adults and that kind of stuff today, right?
Mm-hmm. Because, I mean, we kind of really set it up right in the last podcast, breastfeeding and how important that is, and looking at the tongue ties and the frenum attachments. And those that didn't realize it or weren't properly diagnosed, or maybe were diagnosed, as you mentioned last podcast, and they were at an age where maybe they had a reattachment. Like, what are some of the things that we're identifying in these types of kids?
It's interesting because I've heard dentists and pediatricians say that myofunctional therapy only works for kids like 10 and under, or myofunctional therapy, it's not for adults, but really it's basic stuff that anyone at any age should be doing. And like I said, I think in the first episode, it's what our bodies are designed to do, is breathe through the nose. The tongue should be on the palate. Like the mouth should be closed. Like these are not things that we should have to think about or learn from a therapist. Like these are things we should all just do on our own. So kids who get missed and they were tongue tied, or maybe the pediatrician said, oh, the tongue tie doesn't matter, and now they're 6, 7, 8, 9. These kids, to be like super direct, they're kind of behind on the growth trajectory for that craniofacial development. Because if the tongue hasn't been in the palate and they've been breathing through their mouth, they're going to have facial structures that are more set back, more probably class 2, retruded mandible, in some cases class 3, but they're all usually mid-face deficient already pretty early in life. And so this is where it gets a little controversial on the orthodontic front, is that a lot of orthodontists will want to wait until they're older, take out premolars. And that's one philosophy that I just think it's waiting too long. And, what else can the orthodontist do? If they have a narrow, small mouth and they need to straighten out the teeth, it makes sense. Okay, takes them out, straighten them out, whatever. But there's a whole new movement of orthodontic treatment that's focused on, what do we do with these kids? We can see they're narrow, they're set back, they're mid-face deficient, they don't have space for their tongue. What do we do with these kids? And early intervention is the key. Guiding growth is the key. Myofunctional therapy is critical no matter what you do orthodontically. You might need you definitely need a combination, but these kids, I think parents have to realize, like, if you've been mouth breathing your whole life and you're 7 or 8, your maxilla is too far back. You are probably narrow. And unless you have really good genes and you can somehow avoid that, it's going to happen. So what can we do? That's where now there's a whole new wave of orthodontic appliances. I know we mentioned Healthy Start. We were talking about that. Healthy Start, Myobrace, even Invisalign First. Have you heard of that?
No, but I did hear Invisalign was kind of going in that airway, down that pathway, right?
So Invisalign now is doing like kids, like young kids. And so they call it, Invisalign first. Yeah. So, they're all trying to fill this void on like, what do we do for kids who are like under 6 when most orthodontists don't really, they say, oh, wait until like the first year molars are in. But what we're seeing, and from my perspective and in any like airway dentistry perspectives, is that these kids, you can tell they've got issues. Their baby teeth are crowded, they're narrow when they're 3 or 4. So now we're saying, oh, we see the problems today. We're just going to wait 3 years to correct that. That's crazy, right? So getting in early with some of these preformed appliances, they're called. I don't know if your listeners are familiar with Myobrace or Healthy Start, but we can kind of talk about those. And, the idea is, in theory, they're supposed to be a way to start kids early, breathing through the nose, getting the lips together, getting some of these soft tissue dysfunctions under control, so that it's not to say, some of the companies will say like, oh, you can avoid braces later. I try not to say that. Sometimes I think those preformed appliances are not enough and kids do need more. And so I love meeting general dentists or orthodontists who will put ALF appliances or some sort of expander in a 4-year-old. That's amazing, because why not start as early as possible? The argument is burnout. Kids will get burnt out, but I think it's way better to be burnt out with an expander at 4 or 6 than to have
versus
a lifetime. Lifetime of problems. Exactly. So you kind of have to weigh like, all right, a burnt out 4-year-old with orthodontic stuff or a 6-year-old or whatever is, I think, by far a small issue compared to the adults I see that struggle. It's like,
they adapt so easily. They do. These kids. And there are far more,
they're resilient.
Significant issues like kids have to deal with. I know I have multiple ones. One has a trach. One has had let's all put it in perspective.
Yeah, exactly.
It's not that bad.
So those appliances, I think they're filling a void because there are a lot of general dentists who are getting into airway dentistry and trying to work with orthodontists, and the orthodontists are saying, oh no, just wait. I think a lot of orthodontics, they're not pediatric focused. They're not trying to do 3 and 4-year-olds. Like they're like, I want to wait till they're older. It's hard, right? It's super hard. And unless you're like super passionate about babies, like, and kids, you probably would have gone into pediatric dentistry. So I know that just behavior management and like the logistics of seeing 3 and 4-year-olds, it's hard. So I think that's where some of these general dentists, like I mentioned Tracy Nguyen, she's really prominent on Facebook, and she is one of these general dentists who's expanding 3 and 4-year-olds and starting early, and then sending them to the orthodontist when they're, she's just like, I can't sit by and do nothing. Like these kids are growing so much. There's that statistic I told you about. It's something like 90% of craniofacial development is complete by age 7. So what are we doing? What are we doing if we can capture this growth and guide it so that these kids can breathe better, sleep better, function better? I really appreciate those dentists who are trying to start early, because it's obviously harder.
And we talked about last episode, being an advocate, right, for your kids and for patients. And I do hear more about airway orthodontics and orthodontists taking kind of a different route than what they learned. And so, do you have like certain questions that you personally ask if you're working with the orthodontist?
Yeah, I can tell pretty quickly if an orthodontist is like interested in airway and myofunctional stuff. Usually I'll just ask them, do you work, what do you think about like taking out tonsils and adenoids? Do you work with ENTs? My question is like, do you work with a myofunctional therapist? If they say no, then I know they are not even on that path at all, because the myofunctional and the airway stuff overlaps so much. So most of the dentists who are into the myofunctional space will also be looking at sleep apnea and all that stuff. So I'll usually just ask flat out about, like, in a nice way, like, do you work with a myofunctional therapist? Have you heard of it? And that pretty much tells me all the answers I need to know. But you can also ask about training, like a lot of doctors who are trained like through SPEAR education, which is a big group. SPEAR is really promoting myofunctional therapy and airway, and I'm super impressed.
I agree. I just saw that the other day at Coyce.
Yeah, Coyce is.
Dawson.
Dawson is. There's a Spencer study group. They're talking a lot about it.
Jameson Spencer?
Yeah, that one. So, there are a lot of these amazing dental organizations, like dental training CE organizations, that are now talking about myofunctional therapy. And I think this is like groundbreaking for me. Because like I said, remember in the first episode, I was begging dentists to pay attention and to like refer to me and to like look at the stuff, and like no one was that interested. But now the times are changing, and dentists are really, they're eager for information about this stuff. So I think the implementation is where we're getting stuck a bit, because it's great to have all the knowledge, but like, how do you change the way an entire office operates, and how do you be profitable? And so that's really, I think, the biggest question right now.
So can I go kind of down a quick checklist and have you add to it about like, if we have a child or adolescent sitting in our chair, what are some things that like we're like, start making that critical thinking process happen?
Yeah.
Rampant caries.
Yes. So exactly. Mouth breathing is very connected to rampant caries, or just, it doesn't have to be too crazy. It can just be like an increased risk in general. It changes,
1 or 2 every time they come.
Yeah. It changes the oral microbiome when we mouth breathe. It changes the bacteria, the pH, all that kind of stuff. So it also affects perio. And this, I want to say, I wish I had the article, but I think there is one article from like a periodontal journal talking about tongue thrust and periodontal issues. But if you look at all the people with the worst perio, they probably have myofunctional issues. So that could be tongue tie, tongue thrust, mouth breathing. And so there's a huge overlap with just like the basic dental stuff. You don't even have to get into the airway stuff. So that's one for sure.
Oh, I was going to say open bite.
Yep. Open bite. Exactly. Not everyone has it, but open bite or orthodontic relapse. Yep.
Well, okay. So that's an interesting topic. We haven't established fully, but I mean, pretty much I check off every box for having myofunctional issues. Yeah. And I still have a lower lingual retainer.
Interesting. Okay.
So my history started as assistant in an ortho practice. That's where I started my dental journey, because I started working for my orthodontist that treated me for so many years. And I have said so many times, when you get your braces off, get a permanent retainer, because your teeth love to go back to where they were. And, it was something that I heard very early on in my career, like teeth like to be where they were originally. So they always kind of find their way back. And now I'm like, so many tongue issues that I didn't talk about.
Well, it's not that teeth like to go back to where they were. That's true. But if it's like, if you change the teeth, but not the muscles and the soft tissue and the habits, of course the teeth are going to go back. So the buccinator muscles, the mentalis muscles, these, if you've been using those dysfunctionally, and the tongue, of course, but all these muscles, like they're supposed to be balanced. So the tongue up on the inside, filling up the entire oral cavity. The buccinator's not like squishing or clenching or like, think about sucking on a hard candy. You shouldn't be swallowing like that all day. Like that really, like that strong contraction of the buccinators, the pulling of the lips, or the orbicularis and the mentalis, all these muscles we learned about in anatomy. When these muscles are dysfunctional, the teeth will move. And so it's that harmony between the tongue and the lips and face. If that is not in harmony, so if the mouth is open, the tongue is low, teeth will move, and teeth move easily if there's soft tissue issues. So I wish, it should be just like a big red flag. Like if you're in orthodontic treatment, you should also be getting, muscle treatment for your mouth.
Well, it's like having a hip replacement, but not the therapy after.
Exactly.
Like that would be almost unheard of.
Exactly. So,
but here we do it in dentistry.
Yeah. Myofunctional therapy is really just physical therapy for the muscles of the mouth. And we work a lot on habits and postures and breathing, but you have to have a certain degree of muscle control of your tongue and tongue tone and coordination. And there's so many things that if kids learn these things early on as part of their orthodontic treatment, dental treatment, even if they don't have airway issues, like maybe it hasn't gotten that bad yet. We're kind of talking about the more extreme stuff with that, but just a kid with a lisp and mouth breathing, they have little signs that don't seem like that big of a deal, but they don't go away. Like those things stay with you for life until you learn to change them and use your muscles. And postures and all that stuff differently. So
an obvious on the checklist would be mouth breathing.
Mouth breathing, open bite, like you said, high risk for perio and tooth decay, but then also narrow palates. If someone has a high vaulted, narrow palate, they are definitely, if their tongue wasn't up there, you can look at the palate and you can tell, does the tongue fit in there? If the rugae are really prominent, the tongue probably hasn't been up there. Your rugae should be pretty smooth. If people have like a super like hypersensitive, like, oh, I can't use a Sonicare. It's just like, it's so, the vibration is so strong.
Interesting.
Yeah.
Okay. Speak more on that, because I have always had that as a, like, because now I'm at a point where people are just tossing toothbrushes at me and I'm like, I don't need 17 Oral-B's or Sonicare.
Yeah.
So I give them to people, and it's so funny that feedback that comes back to me. And even back in the day, I was more of a Sonicare rep, or not rep, but a Sonicare recommender,
advocate, yeah.
I guess, in my perio practice. And I would have these patients come back and you're like, I just can't handle it. And so then I would always say, go back to the Oral-B or something like that. But I didn't realize there was,
well, I noticed it in myself and working through patients with myofunctional symptoms all the time. You start to see patterns just like in your hygiene perio practice. Like you start to just see like, geez, all these people. And I remember as a kid, the palate, like the roof of my mouth was so ticklish. It was just like so sensitive. And that's from the tongue not being up there. Like your tongue should kind of desensitize the palate. But if you meet these people and they're just like, I cannot stand having my palate touched or the vibration of the Sonicare, I think it's because they just have a lot of these. I like to say that, and then this probably isn't very technical, but it's almost like the brain, the neuromuscular pathways are not as good as they should be. Like the brain is not connected to like kids who can't breathe through their nose and then they have the tonsils and adenoids taken out, but they have been mouth breathing for the first 10 years of their life. Their brain doesn't know they have a nose. Like they haven't learned to use and to connect. And so it's kind of like, it goes back to cranial nerves and a lot of really kind of out there stuff, but you're just not coordinated. You're not able to connect with those parts of your body. And so once you kind of get that integration, that neuromuscular connection, it comes together easily for people. And I see this throughout therapy with my patients. And in the beginning, it's like, they don't know how to move their tongue left when I say go left. And you've probably seen that cleaning people's teeth. Like they don't know where their tongue is, how to breathe through their nose, what their lips are doing. Like they have no coordination or connection. And so, yeah, those patients, people who struggle, I mean, everyone struggles to some extent with a rubber dam, but people who really struggle, if you're not used to breathing through your nose or you don't know how, or you can't, and now you have a rubber dam and your mouth is your main mode of breathing, it's scary. It's hard. And you feel like you're going to die. And same with the ultrasonic cleaning with the water. The people who are like, I have to have the suction, you know, they're like, you're waterboarding me. You know, you've probably heard that, like, I'm going to drown. Those patients, they're used to breathing through their mouth. So if you are breathing through your mouth, but there's water in your throat, like it's scary. It's hard.
You feel like you're drowning.
You feel like you're drowning and it's super stressful. So I used to think those patients were just kind of weird and crazy. You know, like, so annoying. But there's like legitimate reasons.
They're crying for help.
They're totally. And so now I look back and I feel so bad. So I think those are signs in the chair. Things that we're starting to connect, like massive tori, clenching, grinding, and tongue tie. It's like, if you look, most of the people with huge mandibular tori, or even like the exostosis on the maxilla, a lot of them are tongue tied. And there's different theories of that have been floating around. But they're not functioning correctly. So the bone, for whatever reason, is like just going crazy. So I'd love to get a study on that. But I hear it from these really smart people that I'm like, oh, you know, I believe what you say and I know you have the research. So that's been one that I feel like it wasn't proven for a long time, but now it's like, no, this is legitimate. So
how about dimples?
You know, people do talk about dimples with buccal ties. I know, so there is a correlation, not a direct link through research, but the MTHFR gene mutation. Have you heard much about that?
Yes.
So that's connected to like cleft lip, cleft palate, spina bifida, a lot of midline issues. And so people kind of they kind of jump to the conclusion that it's also connected to tongue tie and lip tie. But I don't think there's actually a study showing that. But also dimples in the chin. So that can be connected to MTHFR, potentially lip ties, potentially. It doesn't mean if you have a tongue tie or lip tie, you're guaranteed to have dimples. But I always like to look at, the correlation. There are patients who don't have any of this stuff, but they still have myofunctional issues. So you can always have the outliers, I guess, the people who they have great airways, but they still, for whatever reason, have sleep disordered breathing. Those are the tricky ones. They're not going to be obvious in your chair. And I think the challenge too, as a hygienist, when you are identifying these symptoms in someone in your chair, is they're not expecting it and they don't always connect with it. And so if you ask someone, do you think you breathe through your mouth? They will always say no. No one will say yes. No one. So you can't ask your patient oh, do you think you have a tongue tie? Or actually tongue tie, some people will say, oh yeah, my doctor told me when I was born that I had a tongue tie, but I'm fine. But mouth breathing is one of those things most people will not admit to. So I usually ask, do you think you breathe through your mouth at night? And they'll say, oh yeah, I do that. Or, people admit to it at night, but not during the day. And so I'll say instead, do you think your lips ever rest apart? Or do you think your tongue rests in the bottom of your mouth or the top of your mouth? What do you notice? And so that people will usually give more feedback, better feedback on that. But it's amazing. People always I know that their tongue is not in the top of their mouth. They're no, I think it's in the top. So I think people are either in denial or they just don't know and they're unaware. And so you do have to kind of be a detective and look at all these other things. If someone has asthma in their health history, they probably mouth breathe. It doesn't have to do with nasal congestion. It has to do with you feel like you can't take a deep breath. You feel like you're not getting enough air, oxygen. And so you end up mouth breathing.
Open your mouth and take bigger gas.
Yeah. Ooh. Which is really counterproductive. If you have asthma, the best thing you can learn to do is breathe through your nose, and it will actually help the asthma symptoms. So yeah, that takes us to a whole Buteyko breathing. I don't know if any of if you've ever talked about that, but yeah.
I don't think we have, but one of the books I'm currently trying to get through and finish is The Oxygen Advantage.
That's so good. Yeah. Patrick McEwen, he wrote that book and he's probably the most famous Buteyko breathing instructor out there. He's so nice. He's an amazing person. And I always talk about his books because he's just so brilliant. And I think the field of Buteyko breathing overlaps a ton with myofunctional therapy because of what you mentioned. I think on the last episode that or did you talk about nasal nitric oxide or the CO2 levels?
We didn't actually.
Yeah.
We didn't. Yeah. So if I could just really give a few more just checklists and move down. Why the heck is nasal breathing? If you haven't heard the first airway series, this will be a good trigger to go and just a little tease to go get deeper into that.
Yeah, listen to others.
Scalloped tongue.
So that there's different reasons for that. Scalloped tongue can mean the person just has a small mouth, less tongue space. And a lot of times when they sleep, they're pressing their tongue against their teeth to get it out of the airway. So scalloped tongue, definitely people who are clenching and grinding, bruxing, it can be airway issues or tongue posture issues. Basically, if somebody's really grinding their teeth, they can be trying to move their mandible forward to open up the airway. Subconsciously at night, obviously. Most people won't know they do it. Or there's also theories about when the tongue is not able to make contact with the palate, the TMJs are very unstable and our body's looking for stability, so we clench. The tongue to palate contact is super critical while we sleep. It should stay up there. So people will clench looking for stability. Then obviously this has a whole counterproductive effect with muscles compensating in the neck and the teeth wearing down and jaw pain and headaches. So I think and this is, maybe people would criticize this, but I really think in every TMJ case, every case of clenching and grinding, I think there's some myofunctional component. I don't think that it's necessarily the end all be all, but I think rather than just giving people night guards, we need to be looking how are they breathing? What's going on with their tongue? Can they make tongue to palate contact? And I love working with adults who have TMJ issues because they get such dramatic decreases in their pain. And it makes me feel like, wow, I'm really doing something. Like when you can help people in pain, it feels so good. And especially because they've usually had pain for a long time. So it doesn't mean they don't need a night guard or orthodontic expansion or whatever, better occlusion. But I think that especially with our TMJ patients, we have to be including some sort of myofunctional component or they're not going to get better.
You know, we go through our careers trying to do what's right for our patients using the knowledge that we have. We don't know what we don't know. And one of the things that I have been a big proponent of is guard therapy at night guards, whatever, occlusal guards, whatever you call them. And now I look at it and I'm like, oh God, there was such a bigger problem.
Yeah, but you don't know.
This was just a crutch, right? This is just it was protecting their teeth at least, so they weren't fracturing teeth, because I work in I worked in an implant driven practice. So we were just seeing fractured teeth left and right, and we're placing these implants. So it was like a religion in our office. Everyone gets a guard. And now I totally see that what you're saying is it's a bigger
but no
issue.
We just don't know. And so I think that's the hard part is we have all these protocols and all these things that all of us learn in dental hygiene school and dental school and stuff like that. And now we have this new information coming in and we just don't know what to do with it. And some people will say, oh, it doesn't matter, and kind of deny it. Some people will embrace it and be like, how do we figure this out? But I feel like I think we'll look back at this time in dentistry in like 20 years and be like, whoa, like this was the beginning of doing dentistry in a different way. Was this era right now? So that's my theory on it. But
God, that would be so great if this was and you're front running it. It's amazing. So ADHD patients, I know that's an airway thing too, but is tongue tie?
So tongue tie, I will talk about that because our traditional training on tongue tie is not what a tongue tie is. So I mentioned Dr. Zaghi earlier and the Breathe Institute, and really they're changing how we look at tongue ties. And their big thing is it's not about how far you can stick out your tongue or tongue. It's not about that, like the appearance. It's about the function. And even if you have signs of a tongue tie, if you can function fine, then it's fine. But if you can't function fine, then it's not. So I really like what they're doing because they're doing a lot of research, and they are the big reason that myofunctional therapy is getting recognized, because we're having research. Like there is one article by Dr. Zaghi and Audrey Yoon and a bunch of other people in this space that now says myofunctional therapy for people who have sleep apnea and sleep disordered breathing, it can decrease the AHI by 50% in adults, 62% in kids. And a lot of that has to do with the coordination and the muscle tone, but also releasing the tongue tie. So they have come up with a whole new classification system on tongue tie that's like a grading scale. So grade 4 would be the worst, and grade 1 is the most optimal. So, but they're grading it with compensation. So you can be a measurement, you can be a grade 3, which would be second from the worst, but then you can compensate. So you could be a grade 3 compensating to a 2. So it's almost like a false, like you look better than you are functionally. And so I really like this. It's focused on function versus just like how many millimeters of free tongue is there? And that's really changing things. So when we look at it from a functional perspective, it makes more sense on why we see so many tongue ties. And so I think if anybody looks up the Breathe Institute, Dr. Sarush Zaghi has amazing resources. He does everything is like open to the public. Like if he lectures anywhere, he says you have to make this available. You can't sell it. Like it's all open source. So he has tons of free content and lectures that he's given because they're really trying to just get this information out there. So, but yeah, tongue tie, it's not full ankyloglossia, and it's not just like, can you not stick your tongue out, or is there a heart shape? There's a ton more to it.
That's actually very good. Thank you for sharing that with me, because I think in the last episode, we can talk about how do we implement the myofunctional world. And I would love to talk more about even just what can you do with your tongue? Like you mentioned earlier, the patient that can't put their tongue to the left. And I often do this with my oral cancer screening. And you said two things, or you taught me two things today where I was like, well, this is easy implementation, because I could do this on my oral cancer screening or my oral abnormality screening. And that is when I put my finger in the roof of the mouth. And if I can't tell you how many times people giggled, like, oh, that took out. And I'm like, oh, like what an identifier. Like, their tongue is up there. And then I might do my tongue examination a bit different because I have my patient put their tongue on the side of the mouth. I don't grab the gauze immediately and pull it side to side. I have them stick their tongue out and then I grab it and pull it out and look further. And then I let them rest. And then I have them do left to right. And then I grab on either side of those. And for me, I don't know why. I think my dentist did that and I just kind of adapted.
Yeah, no, it's good. So it's kind of like
doing it.
It's a myofunctional test on some ways. So one of the exercises that we do, and I'll try to say this as clearly visually as I can, because I know that the listeners can't see me, but basically if you open your mouth about halfway and you move your tongue left to right, you should be able to do it. Yeah, I can see you doing it. You're doing good. You should be able to do it without shifting your mandible and without dragging your tongue along the lower teeth and the lower lip. So you should be able to elevate your tongue enough that it's just touching the corners. Yeah, exactly like that.
Okay.
Without like rolling or dragging and without shifting the jaw left and right. And most people who have myofunctional symptoms, their first time doing it before they have practice, they will either roll the tongue along the teeth or lip, or their jaw will shift with their tongue when they move it left to right. So it is just a really quick screening thing that you could do. And then once people know how you want them to do it, you can say, well, can you try doing it without moving your jaw? Can you try doing it without letting your tongue drag along your teeth? And then if they try, like, and this will drive people insane, especially like perfectionist type of patients. Like if they're like, I can't do that, like, why can't I do that? It's so hard. It will motivate people to like practice it. And so I do it during my exams, my myofunctional exams. And people are just like, that's so annoying. Why can't I do that? Like that should be a skill I have, like they think there's something wrong. So, then that also helps demonstrate like maybe you just don't have that coordination or maybe you're tongue tied. So, having that experiential component where people get to try something and then they struggle and they're like, what's wrong? Why? It's actually really helpful. So
I would love to now move into nasal breathing, why that matters to you as a myofunctional therapist. I know we've said, the tongue should be up in the roof of the mouth. We should be breathing through our nose, but why does that matter to you at the end of the day? Like, why is that even something that you care to talk about?
I know. And I have to talk about it so much because I do feel like it is one of those things that almost sounds silly to care about if you don't understand it. So when you breathe through your nose, the air that comes in through your nose is cleaned and filtered. We all know that. But there's two things that people don't realize that I think are equally as important, if not more important. And that's one, your nose is designed to slow down the air. So it goes into your body. It's not so fast and harsh when it comes in. That's what our turbinates are for. They cause turbulence. So they slow down the air. And part of that is when the air gets slowed down and it goes through this turbulence process, we also have a release of something called nitric oxide. So nasal nitric oxide, it's only produced in our nose and our sinuses. And when we breathe through our nose, we get that molecule. And that molecule is super helpful because it's antibacterial, microbial, it's anti-inflammatory. And so it really is meant to, it's a health molecule and it keeps our, it's like a perfect system when it's working the right way. When you breathe through your nose, you get all of those things. The mechanism of slowing down the air is important because we are actually designed to have CO2 building up in our bodies. That's what triggers our respiratory drive. So when we mouth breathe, there's a ton of things, like we don't get nasal nitric oxide, but we're also like off gassing, like we're losing too much CO2. And we think it's just a waste molecule, waste gas. We need oxygen. But if you don't have a certain level of CO2 in your bloodstream, in your tissues, it's actually not healthy for breathing. We can't absorb the oxygen the same way. So our nose slows down the air, so it goes into our body more slowly. It's not so harsh and fast, but it also allows CO2 to accumulate. So that triggers our respiratory drive and it's comfortable and easy for us to breathe through our nose. You can tell when people aren't used to breathing through their nose and what's actually happening. They're not used to elevated CO2 in their body. And if you're reading The Oxygen Advantage, you're probably learning all about this. But they have a really low CO2 tolerance. So kids who are just like, oh, I can't breathe through my nose, or adults, even if you know the nose is not blocked and it just feels uncomfortable for them, it's just they're not used to having that level of CO2 in their bodies, which they have to adapt to. So that's part of the exercises of myofunctional therapy, are to help people adapt and get used to operating with this higher level of CO2 in our body and our bloodstream, which we're supposed to have for healthy, optimal breathing. So that involves nose breathing and breathing less, not like big gulps of air, like big breaths, shallow breaths. We need deep, slow diaphragm breathing, really. I think that's pretty much the three things, and through our nose. And if we have that, we'll be healthy, we'll be less anxious, we'll perform better athletically. You're reading that book. There's a whole movement of people who are trying to like run marathons and do like Ironmans and be like physically active while having tape on their mouth and breathing through their nose for exercise, which is super hard.
So I would love to talk about that, because I actually do follow the hashtag nasal breathing on Instagram, and I see tons of people taping their mouth. I actually tape my mouth at night.
Yeah, I do too.
And I want to talk a little bit more about that. So I personally heard this, I think first with Joy Moeller, then I can't remember one of the other conferences I went to. And the last was Kathy Bassett, who is a hygienist in the Washington. I know her. Yeah, she's amazing. Yeah. She's been on the podcast twice. Listen to her.
Really? I didn't know that.
Good.
She is.
Yes. And so she's the one that said it in her conference. And that was the last time I was like, all right, I'm going to give this a try. This is the weirdest thing I've ever heard, but it takes me a few times. But if I keep hearing consistent science to back it up, I'm like, I'll give it a try. I tape my mouth. I was like, I'll give myself 2 weeks. And I'm a grinder. I wear my night guard. I also wear an eye mask. Now I was going to tape my mouth shut. And I'm like, and wonder why this girl's single. Like, who wants to go to sleep with this monster?
No way.
No, but it's like, I look like I've been straight up kidnapped when I go to bed. And I was like, I'm going to give 2 weeks. Right. And it took, so 4 days into it, I traveled, and it wasn't a part of my typical armamentarium to pack and take with me. And I forgot my tape. And I remember that first night in a hotel, and it was the most restless night's sleep. And I'm typically, I would say I'm a good sleeper. Obviously, I have a ton of parasomnias, and I've learned a lot more about my sleep. But overall, I would have said I was a good sleeper. And I kept waking up to my mouth falling open.
Yeah.
And even after those 3 days, I was shocked.
I love that story that you just said that, because that's how I feel too. But the mouth tape, there is a learning curve to it. And the thing is, you need to practice during the day, I think, for the optimal, to be optimal with nighttime mouth taping. And then if you are traveling, there is something, this is a cool fact that I learned. The first time that you sleep in a new place, like a hotel room, you have something called the first night effect. So you'll never, like, half your brain, like there's one side of your brain that literally will not let you get into deep sleep because of that evolutionary response of like, I'm in a new area, I have to stay safe kind of thing. And so that's probably the combination of why you slept so bad. But with mouth tape, it's a really amazing, super powerful tool. But I always am cautious with telling patients how to do it. I usually say start during the day, or like before you go to bed, if you're reading or looking at your phone or watching TV, put the tape on while you're awake and give yourself like 20 or 30 minutes to adapt, because it's new, it's weird, it's on your skin. It's just like, it's different. And then don't give up if you don't like it the first night. I do say give yourself 2 weeks. So after 2 weeks, you should adapt. But the most important thing with mouth tape in adults is to think about your tongue posture as well. So put the tape on and use it as a way to check your tongue posture. So your tongue should be up in your palate, put the tape on. And then the ideal goal is, if you're doing it during the day, your tongue is up. This is like the final stage of therapy with patients. As they fall asleep, I want them to check their tongue, put it in the right place, and then they have to wake up with it there too. So the tongue posture with the tape and the nasal breathing at night is the key, like, to all of it. So
yes. And I think that's a great point to make, because I've heard or read some controversy on Facebook and people kind of novice at this and just kind of doing it on their own, which is what I did for sure. And I can tell you that I need to work on my tongue posture, because I feel like it's a little bit of a crutch again. Like I'm not really going the full length of therapy to correct it. But I'm curious, do you feel like even with good tongue posture, there's the chance to still pop your mouth open at night?
Yeah, especially if your tongue's not up, it will pop open, or the lips will be taped, but the jaw will, you'll feel your jaw drop. So I think if you practice it, it'll get better. But do you think your tongue is up in your palate all day?
No.
Okay. So then it never will be at night.
Yeah, and I totally get that, which is, I'm just being kind of like slack about getting the full therapy that I actually need. I only do the minor, like if I hear one technique at a thing, I'll do it for a little bit, but I need some serious help, like tongue posture.
Yeah, I'll totally help you. So the other thing I'll say is just related to kids. I feel like it's important. Like a lot of parents, they read this on Facebook and they're like, oh, I'm just going to tape my kid's mouth. It's really important to get screened by an ENT. Like we don't know what's going on with tonsils and adenoids. Like if a kid is mouth breathing, there's a reason, like it might be that their nose is so blocked up they can't actually breathe through it well. So before parents just start throwing tape on their kid's mouth, you can test it during the day. I think put it on, start with 5 minutes. Can they do 5 minutes? And then put it on. Can they watch a movie? One of the exercises I give kids is actually like do a physical activity with tape on your mouth. Like I had 2 little boy patients. I'm like, okay, they love playing basketball. They're like 6 and 8. I'm like, play basketball with tape on your mouth. Because it's like a good way to get nasal breathing with a little bit of elevated heart rate. But the very last thing I do is have people tape at night. I feel like they have to get really comfortable, really good during the day, be screened by an ENT or, a dentist with a cone beam or something. Like make sure there isn't like an actual obstruction, because that's where it gets sketchy, like we don't want to be like tape your mouth and like you can't,
and people are dying in their sleep.
Totally. Yeah, we don't want that. So that's where I think it's so silly. I mean, that should be common sense, but a lot of people don't think about that. So
a lot of people lack that in life.
Totally.
So what are some other things that maybe we haven't touched on as far as caring for or adults and adolescents with myo, or more like, haven't we talked about that's an ID for it, like that we need to be
snoring. I think anyone who snores, so I look at sleep disordered breathing. It's an umbrella topic, and I know your listeners have already heard probably a lot about this, but obstructive sleep apnea is at the far end of the spectrum. Like that is like end stage breathing problems. So beginning, like if you look at this as a continuum, like a spectrum, the very beginning of that is mouth breathing. If you go a few steps worse, it's noisy breathing. And this can be day or night. A few steps worse at night, it's upper airway resistance syndrome. And then a few steps worse is obstructive sleep apnea. So I think it's important to realize that mouth breathing, day or night, you're already on that path of getting worse breathing symptoms. So sleep disorder breathing symptoms. And so mouth breathing is so big. It is a symptom in itself. It's a problem and a symptom of something bigger. So yeah, I think that knowing that and being able to educate patients when they're just like, why does this matter? It's a risk factor for a lot of things, but it also tells us there's underlying reasons why you're doing that too. So sleep, snoring, if anybody's in your chair and they say, I have sleep apnea, it goes the other way too. People who have sleep apnea probably need myofunctional therapy. They probably have under-recognized or undiagnosed myofunctional symptoms like tongue ties. And so you can help a patient who already is at that end point where like they've got obstructive sleep apnea, they wear a CPAP. A lot of what I do is help people manage those symptoms. And I mean, if you have sleep apnea, you're probably mouth breathing all day, and it just makes your whole life worse. It's a quality of life thing, I think. Just mouth breathing alone, you will feel tired and less rested just from that. And I can tell from my own experience when I learned to breathe through my nose, which sounds so funny, but after I got down this path and I started taping my mouth and breathing through my nose all the time, my world changed. And I don't think I had sleep apnea. I didn't have anything going on, like sleep issues, but I realized I was so much more clear, like mentally alert. And like we were joking about, I'm just a hustler. So like I was like, I'm in dental hygiene school. I run marathons, like all through my early 20s and my teens. Like I was really active, athletic. So I never would have called myself a tired person, but I realized how tired I actually was. And I was really good at like pushing through. I feel so much more well rested and I sleep so much better. And I feel so much better in my 30s than I did in my 20s. And like, I'm in my early 30s or I'm 35, but, I just turned 35, but I think 35 compared to 25, I feel so much better because I know all this stuff now. And I just I'm a perfect example of somebody who, if I didn't correct these issues when I was 24, 25, but by now I'd probably have sleep disordered breathing, upper airway resistance syndrome for sure. I'm like a classic structural case for that. So if I was just mouth breathing over the past decade, my symptoms would be getting worse and worse and worse. And I'd probably be miserable now, but instead I feel great. So I'm just glad I knew that.
So good to hear that. I just recently heard a term and I don't really have an exact definition to go behind it, but I have an idea. Reverse swallowing.
I feel like people describe this different ways. Some people will call a tongue thrust a reverse swallow. Some people actually call reverse swallowing like where the lip gets tucked under. Like, I don't know how to describe it, but where the lip will kind of contract and the buccinators contract more. So I think it's a dysfunctional swallow. You can think of it like that. I feel like people have different definitions for it. So, but you will hear for tongue thrust, you'll hear infantile swallow, reverse swallow, perverted swallow, which is a weird one. I feel like that's from like the 50s. And then, tongue thrust swallow. So those are all, I feel like in my field, those are all used interchangeably.
You just reminded me of a check off item that I was curious about. Lip curlers in your chair.
Oh, okay. Like,
is that a sign of a myofunctional issue?
Describe the type of lip curling, like curling under or like flaring
when you're
out, or
trying to scale those lower anteriors and their mentalis muscle is just like curling up, right? And they are pushing
pushers,
you up
like
and out. Yeah, they're pushing you out. You can't fulcrum on an anterior to save your life. And then you almost always see brushing issues there, right? Like that gingival margin.
I would say that's like a hyperactive mentalis. And I would say for sure that's a sign. If you notice that on somebody, start to look at, do they have a narrow palate? Do they have signs that they've been mouth breathing or they have myofunctional issues? Like, I would say use that as a clue to start looking at other things and then ask them about it, because those are tough. Or people who you can just not get the mirror in to retract their cheeks. They're so tight and like almost like forcing against the mirror. I think those are all signs of oral facial muscles being misused because of dysfunction. So it's definitely, there's something going on. And so I would say use that as a sign to like look further.
Because now I think about like all those patients that I've seen that are my typical lip curlers. And for me, what I can think back on is mucogingival defects down there. They had lots of mucogingival defects, frenum attachments, or recession. As you kind of taught us, those are kind of pretty indicative signs of some dysfunctions. And for me, I always like, they're protected, like that tissue's thin, that biotype's thinner, it probably is a little sensitive. Like I was rationalizing that in that way.
Yeah.
Man, I wish I could go back and see those patients.
I know. I think that's probably just part of a bigger thing going on. That's probably just one symptom of, I wouldn't be surprised if they had tongue ties or mouth breathing or some sort of just myofunctional component there too. These things are super common. I think this is the part of the problem, is that when you start going down this path and learning these things, you start to doubt yourself, because you're like, there can't be this many people with this, like with the symptoms. Come on. Like, this is just like, it's gotta be fake. Like, this is not like every person in my chair is having this stuff. And that's where I think hygienists get overwhelmed, and dentists do too. They're like, really? Like this many people? But Dr. Derek Mahoney, who's a Australian orthodontist, he's compiled like 15 years of research. And I don't know if it's published. I think he's got a couple papers coming out, but 15 years of like thousands of patients. And all of them came to him for orthodontic treatment. And he basically put together all of this data that shows that all these kids with malocclusion, 90% of them had airway issues and myofunctional issues, like 90%. That's insane. Mm-hmm. And it's because it depends on what metrics you're using. If you're using full on obstructive sleep apnea, that's like 1 to 4%. But if you're looking at mouth breathing, if you're looking at restless sleep, if you're looking at these subtle signs that will get worse later, it's so rampant. It is seriously a pandemic and it's not being addressed. And so it's really shocking. I think it makes people doubt themselves, or they think I'm just overdoing it. And it's just not true. So I think that's good for your listeners to know.
Yeah. And one of the things that I keep going back to is like, look at those kids that keep getting decay every time they're coming back. Those patients, perio patients in your adults, all these little idiosyncrasies that we talked about, that lip curling and can't retract with the mirror. For me, I'm always applying this theory of mouth breathing and tongue posture with implant patients, because we talk about mucositis and implantitis and pH control and biofilm management for teeth. But I think this absolutely applies to dental implants as well, because they're living in that same environment. And just because we got rid of the tooth doesn't mean we got rid of all the other things that are going to create
that's really interesting
around these dental implants. The other thing,
and if you wonder why they fail, like why do some implants fail? Then I bet if you look back, there might be mouth breathing or something, some underlying reason why some fail and some don't,
Yeah. And just biofilm accumulation in mouth breathers. If you put that anterior implant in there and they're mouth breathing, I mean, we've lowered the pH control. I think also if they're sleep apneic, I mean, you get your your immunity kicks in at stage 3, right? With sleeping. So if they're not getting there, how do we expect them to respond to our therapy? But I think those are just like low hanging fruit, right? Like your caries patients, your perio patients, your implantitis patients. And then I think as we learn more of these like little, would feel like nuances in our clinical care, the lip curler, the can't lay back, the eye gag on x-rays, all of these things, those are people just screaming for help for bigger problems. And they just feel like another PIA on our PITA patient on our schedule, but it's really a bigger issue.
Yeah. And it starts, like we said, we talked about the babies. It starts really, really young, but a lot of people get missed. I mean, I was an adult when I figured this stuff out, so I technically got missed, but I feel lucky that at least I was 24 instead of 54. I have adult patients who reach out to me and they are in their 50s or 60s. And the reason that they go down this path to trying to have better health is because they get a big diagnosis like obstructive sleep apnea. And they're like, how did I get here? And no one just wakes up one day and has sleep apnea. It's been brewing for decades in most people, and they've had little signs along the way, these symptoms that, a lot of this stuff is preventable if you get to it early enough and if you understand the causes. So the adults that find me on their own that aren't referred, they want to do whatever they can do to try to get a root cause fixed, and there's a lot more to it than just myofunctional therapy, but that myofunctional component is so important for those patients. And finding somebody orthodontically who can help them or release their tongue tie, or, for me, building that team for the patient, it's so important. And, even the patients who do have bad sleep apnea, they benefit a lot from learning how to breathe through their nose. And I try to help them, be compliant with their CPAP. They need that. But the CPAP, I think it's important for us to realize it's not a cure. It's managing, it's keeping that patient's airway open at night so they don't die.
Yeah.
It's critical. Like they need it, but it's a Band-Aid. It's not actually changing anything. It's just managing those symptoms. So most people who get to the point where they have really severe sleep apnea, they need like MMA surgery. Like they need a lot more, but not everyone's willing to do that. Most people are willing to do a simple therapy where they learn to put their tongue up and breathe through their nose. And that alone can be like a life-changing thing for them. And so maybe they do need other stuff because they're at that kind of, end stage of the spectrum. But it's amazing what you can do with simple things, even in your dental chair, telling people their tongue should go in the top of their mouth. They should be breathing through their nose. Like, you don't need to be a full-on myofunctional therapist to give people those little clues. Or like you said, during the oral cancer exam, that's a perfect time to look for this stuff and to just talk about it.
Mm-hmm. So what we're going to do in the next and final episode is talk about implementation of this and what you can do and how do you branch out and what does this look like in like your everyday life, and honestly, how do we make some money off of this? How do we support ourselves and make this business?
Does it pay?
Yeah, does it pay some money?
Yeah.
Because as entrepreneurs, we know that's important.
Yeah, totally. It is.
So I do want to thank you again for your time. This information is so valuable, and we really appreciate you coming on and discussing this with us. I want to actually give, again, everyone your information if they are listening to this single podcast. How do they find you and how do they learn more from you?
Yeah, perfect. You can look up, I have 3 websites, but you can also find me on Facebook, YouTube, Instagram. My websites are sarahkhornsby.com. That's kind of for my online training stuff. I've got myomentor.com. That's more geared towards hygienists and dentists. I have myfaceology.com, and I'm sure you'll link all this stuff, Michelle, but that's more my practice patient oriented website. But you can find me pretty easily. If you Google me, I'll come up. And, if anyone does want to get in touch, you can always email me to sarah@myomentor.com is probably the best email address. So
perfect.
Yeah. Thank you.
No, thank you. And I am sure everyone is just taking it in. And don't worry, guys, we're going to kind of bring it all back around in this episode 4 of this series. So thank you for listening. And thank you, Sarah. I can't even believe that this is part 3. The next one is the last one. I hope everyone is just, mouth dropped open whole time. I'm like drooling, but you know what? Close that mouth because nasal breathing is important.
That was good.
I did just room with somebody when I went to get training for the airflow and GBT and guided biofilm therapy with EMS. And she came in after I'd gone to bed. And she's like, girl, you look like you've been straight up kidnapped. I was like, I told you, like, I don't mess around. Like, if I learn something, I'm going to implement it. So I was like, large nasal dilator, nose filters in so I could breathe better, but not all the mold. I had the eye mask on, my mouth taped, my night guard in. Like, I am ready for a good night's sleep.
That's so funny. I love seeing you like that on airplanes. You just look ridiculous. No shame about if you're in public or not.
Nope.
Huh.
Yeah, no, when you just do it, when you're flying all the time, I'll never see you again.
Yeah.
I'm going to sleep real well. And your germs do not belong in my nose. So I'm going to protect myself.
I love it.
Thank you.
I love
and
it.
Goodbye. But we hope you are enjoying this. We would love for you to, talk to us and message with us and interact with us. You can do that on Instagram or Facebook, LinkedIn. You can also go to our website at taleoftwohygienists.com. You can email. It's either Michelle or Andrew at taleoftwohygienists.com. Write a review, hit that subscribe button, tell your friends if you're enjoying this. We really, really would appreciate that. And we are doing Instagram lives and chairside chats, and we're doing Science Sundays, a lot of cool things happening on social media. Our goal is to bring you content. How can we make you better, less frustrated, providing the most top-notch clinical care to your patients? Because I know that's what you guys want. And so we're trying to figure that out for you.
Yep.
Anything else?
Nope.
Okay. Well, we hope you all have a really great week. Go get at it in that patient care, and we'll see you next week for part 4 of the Myofunctional series.
Take care, everybody.
Bye, y'all.